Our drive to breathe, or breath as people write, I friggin' hate that, is handled by the body's chemoreceptors. They measure the blood chemistry. When they detect rising levels of carbon dioxide, they stimulate us to breathe faster. This is why the asthma patient or the COPD patient gets tachypnic, or why if you hold your breath for a prolonged period of time, you will take a deep breath and then follow it up with a few short gasps. The COPD patient has elevated levels of carbon dioxide because of their lung disease and decreased ability to effectively exhale CO2. They also become chronically hypoxic with low PO2. Now, they used to, and they still do, teach that over time, the chemoreceptors of the patient get so used to detecting high levels of CO2 in the blood that they begin to depend on detecting low PO2 to trigger and mediate breathing. In essence, it's a lack of oxygen that triggers COPD patients to breathe. They call this the hypoxic drive, and surprise, it's never actually been proven. In fact, what we know about the hypoxic drive and COPD, this whole thought that oxygen's going to cause them to stop breathing, comes from a 1949 paper written by two doctors describing case reports in two patients, not necessarily up to today's standards. Needless to say, definitely not evidence-based medicine. In fact, multiple studies have shown that hypoxic drive isn't a thing, but like backboards, withholding pain meds for abdominal pain because it's going to mess up the doctor's assessment, intubating GCS less than 8. This whole hypoxic drive thing is dogma, and frankly, it needs to stop being taught. The short and uncomplicated answer is that yes, chemoreceptors do use low pH to mediate breathing in the COPD patient, but it is much lesser a role than once thought. And you should never, ever let the COPD patient stay hypoxic and withhold oxygen out of fear of ceasing the hypoxic drive and making them go apneic. And those of you who are feeling uncomfortable because this is what you were taught in paramedic school, I would ask you to please ask your instructor why COPD patients don't stop breathing and die when we apply pre-hospital CPAP that is literally pile driving oxygen molecules into their systemic circulation. If this hypoxic drive was a thing, every COPD patient that gets put on CPAP in the pre-hospital environment, because pre-hospital CPAP is generally powered by 100% oxygen, those patients would stop breathing and they would be delivered to the ER apneic. It just doesn't happen. The body's cells that are hypoxic are dying. Treatment is not just, well, let's just let them get more CO2 because that's what they need to breathe. If that were the case, we would be putting plastic bags over patients' heads. If you allow the COPD patient to stay hypoxic or get even more hypoxic, you're not stimulating them to breathe. You're killing them. You're worsening shunt, which is when deoxygenated blood enters into the systemic circulation. Mild hypercapnia does indeed cause an increase in ventilation. Severe hypercapnia, like seen in most of the COPD patients that we encounter in the pre-hospital and emergency environment, because they have been trying to treat themselves for hours to days with home nebs, inhalers, and cigarettes, severe hypercapnia will cause respiratory depression. And as it gets higher, it will actually anesthetize the patient if it gets really high, and then they'll die. Allowing the patient to remain hypoxic and in a worsening state of respiratory acidosis is also going to shift their oxygen hemoglobin dissociation curve to the right. See my video on that. This is going to result in even more inefficient perfusion, and it's going to be even harder for the oxygen to attach to the hemoglobin molecule, so the patient's going to get even more hypoxic. Bottom line, treat the COPD patient appropriately. Treat them aggressively. For the love of God, do not withhold oxygen. Remember, a little bit, some hypercapnia is fine, and it's actually neuro and lung protective for them. Again, some, not a lot. And as far as pulse ox, 92, 93, 94%, those are fine targets. Hell, some people even say as low as 88 is fine. But personally, me, I like them above 90, but that's just me. Don't go worrying about their respiratory drive or titrating a specific pulse ox level. The hypoxic drive is bullshit. You're just not going to make them stop breathing with oxygen.